let's hear his talk now.
Good afternoon, everyone. Right, so what's in and what's out? I think it's very important when you are referring to your physiotherapist that you know you're actively participating in what is getting done with the patient, because invariably they're going to come back to you either for a follow-up or if there are problems. So it'd be great if we can clarify what you should expect from your physios. So these three things I think we're moving away from in terms of modalities these days. Ultrasound, if you think about the depth of the tissue that's getting treated and the notorious inability for ultrasound to penetrate tissues very well on the therapeutic wavelength, I think ultrasound is possibly something that shouldn't be used as regularly, especially when you've got a bit of a time frame problem when you're treating your patients. Diathermy, again, there are much safer ways of doing it. I've seen way too many burns related with diathermy, incorrect placement of pads, machinery that's possibly a little bit old and outdated and a bit faulty. So if you are finding a couple of patients coming back with suspicious looking blemishes on their skin, have a chat with the physios, maybe get them to change the way they heat the shoulder. CPM works. There's enough research around it to show that it does work. The only problem that I have with CPM is that it doesn't engage the patient, right? And we know that the most successful outcomes from frozen shoulder are well-engaged patients who are really doing their rehabilitation properly over a long period of time. They get the best results. So make sure, if you are using CPM, that you're still getting the physios to really engage their patients with a really good exercise program, which we'll talk about now. So physios need to also understand that this is a pathology, right? There's a problem that's happening within the tissue of the capsule. It's not only a biomechanical problem, but there's a histological problem. And we rate that severity of tissue irritability on three levels. There's low, medium, and high. Now, how we do that is we use 5 criteria, and you must have at least 3 of those criteria to be able to fit into a specific category. So these are the 5 things that we look at. Pain on a visual analog scale. The scale that most physios are trained to use is a VAS scale 1 to 10. Pain at rest or at night. End of range pain. Active versus passive quality of movement, and any disability rating score to create some standardized way of assessing your patient. So if we're going to give a rating of high, you're going to have somebody who's complaining of 7 and above out of 10. They're going to have fairly constant pain at rest and at night. They're really going to be battling to sleep. The pain is going to set in well before the end of range of that joint, and the active range is going to be severely limited in comparison to passive range, and they're going to perform very poorly in your assessment, your screen. Moderate is sitting between 4 to 6 out of 10. It's intermittent pain at night and on rest. Pain is at the end of range of motion, and active range is starting to catch up to passive range, but it's not equal yet. And they're performing moderately on their pains, on their assessment. And then low level, pain is 3 and below. They're not really having much pain at rest at all. They're pretty comfortable. You need to give overpressure to the joints in specific ranges to elicit your symptoms. And your active and passive range are pretty equal, and they're scoring very low. If the physio doesn't understand this, they can still use the exactly correct techniques and not get great outcomes, because they're treating a highly irritable shoulder with the kind of modalities that they should be using for a low irritable shoulder. So sometimes have that discussion. If you're finding that patients are not doing well, they've ticked all your boxes and they're at physio and they should be doing well, maybe have a chat with the physio. I'll discuss in a bit more detail now what needs to be looked at when they're treating, because that you might just find there's a small misunderstanding in terms of irritability of the shoulder and the classification of it. So when to use what? So we've thrown out those other 3, and I'm saying replace them with this. We're going to use ice locally around the glenohumeral joint where we've got our inflammatory process happening in the first 1 and 2 phases. We're going to use laser class 4. There is a decent amount of evidence to suggest that the laser is very good for analgesia and for tissue healing in the early phases. joint mobilization, soft tissue mobilization, and exercise. If you remember nothing from what I say today, please remember those 3 therapeutic modalities. They are the most important in getting good outcomes from your patients over their rehab period, especially exercise. But don't forget joint mobilization. There are so many techniques available these days that allow you to put the joint into a very specific position and mobilize the capsule in that position, right? It's not just hands at your sides or arms off the side of the bench anymore or the plinth. It's getting your patients into very functional positions, especially towards the end of their rehab, where they're having difficulty reaching behind them, getting something out of the back seat, or getting to their seat belt, or brushing their hair, or tucking their pants, and you can do a lot of very specific joint mobilizations to really loosen up the shoulder. Soft tissue mobilization. A lot of patients have pain that's got nothing to do with the joint capsule, but all of the associated muscular tissue around it, and getting stuck into all of that muscle tissue with acupressure, myofascial release, and all the other myriad of soft tissue techniques that we can use are very, very, very effective in decreasing their pain. And when patients have less pain, their cooperation to do their exercises increases significantly. And finally, a good exercise program, a well-periodized exercise program. It doesn't mean 10 exercises done 3 sets of 10. It means an evolution of how you work with that person, how you evolve that program, which I'll cover now shortly. And finally, Heath. Heath is great. Use it on all the muscles around the shoulder girdle. Use it on the neck. Use it on the middle back, because these are areas that often have a lot of muscle spasm and responds very nicely to heat. But use it in the latter stages. And extracorporeal shockwave therapy is gaining a lot of traction with research to show that they're very good with chronic fibrotic, really sticky shoulders. They tend to help loosen up the shoulder quite a bit. So key outcomes to ask your physios. What is happening with the pain? Is our pain decreasing? Night pain, is it going away? Pain at rest, is that going away? If it's not, these are red flags to say to the physio, I need to go back to the surgeon, and they should be sending the patients back to you for review. Ranges of motion, external rotation, internal rotation, very, very important because they form a component of every movement. Flexion and extension, compare them to the opposite side, so you've got a relevant point of how much flexibility that person has. Don't forget the scapula, don't forget the neck and the thoracic spine. These areas also need to be mobile, otherwise they will impact on the mobility and the function of the shoulder. Progressive home exercise programs. They've got to have elements of mobility exercises, flexibility exercises, stretching. They need strength exercises that are getting progressively more challenging, and they need to have stability exercises for the glenohumeral joint, the rotator cuff, and the scapula. So take home what's in and what's out. The 7 in green are in, the 3 in red are out. Thank you very much.